Well, thank you for having me today. I feel a little guilty because I may assault you a little bit, your senses, with a little PowerPoint. You'll have to forgive me. And I also want to thank Mike for stealing my presentation earlier today. He really covered a lot of what I'm going to be talking to you about today. If you don't take anything else away from this discussion today, remember that I said technology enables relationships. We seem to forget a lot of the time that when we're talking about healthcare, we're talking about people. Whether it's somebody in your family, somebody you have a close relationship with, healthcare is personal, and it's about people. And when we think about technology innovation, we have to think about what that means for people within that healthcare system. So let me tell you a little story about myself first. I'm a physician from Boston. I went to medical school in 1994, and I thought that I was going to medical school to learn how to make people better through medicine. And after doing a multitude of rotations in internal medicine, psychiatry, surgery, I figured out that I was actually learning how to make people better through relationships, and the medicine was secondary. Now, you'll see here that I think that 3 out of 5 face-to-face appointments could be virtual. And I'm going to get to you later about what I mean by virtual. But firstly, I'd like to ask, how many people in here know somebody with a chronic disease? Okay, a lot of people. How many people have visited a doctor within the past year for an acute illness, self-limited illness? Okay. And then I'm sure that people are very familiar with the concept of either taking an elderly parent to the physician's office or accompanying a child to the physician's office. Now, when people think about technology innovation in healthcare, we usually think about things like gamma knife surgery, robotic surgery, fast MRI scans, new PET scanners, really cool stuff. Stuff that tends to actually add cost to the system, and I think that's one of the responsible factors for our high healthcare costs in the United States. But in my office, I have a phone on my desk, I have potential to email patients, I have a BlackBerry with lots of mobile applications. I can SMS patients. There's an ATM kiosk down on the first floor that I can do my banking at. I don't use too many of these things in my practice. Why is that? I'd like to tell you a little story about how I got interested in this. I finished my medical residency at Mass General in 2001, and I'd been used to getting my call schedule on my Palm Pilot. I'd been used to communicating with all my colleagues with email. And I figured, well, why don't I bring some of that to the office practice? I mean, it only makes sense. I started working in a general internal medicine practice in Boston. And I found that a lot of the patients were showing up in my office for things that I didn't really think they needed to be there for. They were there to follow up their blood pressure, there to follow up their blood glucose, there to follow up their depression. Most of these patients had email or some way to access them, so I thought to myself, well, wouldn't it be useful if I could communicate with you over the email, and perhaps we can actually deliver some care that way. So perhaps you can come see me for one blood pressure visit, and then I can titrate your medicines based on the blood pressures you send me over the email. And I got to say, my patients thought it was a good idea. And I started to do it. And I started to do it with more and more of my patients. At that time, I wasn't too worried about how I was being paid. I was actually being paid a salary, and I had no concept of what being paid for doing what I do was. And that's a different story. So After around 2 months of doing this, I started telling some of my other colleagues that I really like practicing this way. This is really cool. And my administrator, practice administrator, walked into my office and sat me down and said, I hear you're using email and communicating with the patients this way and actually taking care of them. And I noticed that your visit volume is low. It's down. And I'm going to tell you that you can't do that. And that only made me more interested in, well, why can't I take care of patients the way that makes sense? I have this relationship with these people, and they're very happy to receive their information, follow-up visits over email. Why can't I do that? So like any good doctor, I became even more enticed by the technology. And I said, well, what if I try some of these technologies with more patients, regardless of how I'm being paid, since at that point it still didn't matter. I'm going to tell you about a few of my patients, 2 of my patients, that were affected by available technology. The first, this woman on your left, is a 75-year-old female with a long history of congestive heart failure. So she had been in and out of the hospital. She had a total of 6 hospitalizations within a 4-month period. So that looks bad for me. That's definitely not good care. The problem was that she was very, very tenuous. So we could change her medications, and then she would be a little dry, and then if we increased her medication, if we lowered her medication, she'd get sick. So we had to be very careful with her. 2 of those six hospitalizations actually occurred within 4 days of discharge from the hospital. So that's bad. That's bad care. The 6th time that she was discharged from the hospital within those 4 months, we realized we had to do something. On the 5th hospitalization, we did try to set up a home remote monitoring program with her. She lives in an independent living facility. Unfortunately, she didn't want anything in her house. She didn't want any devices in her house. But she did have a phone. So the day that she was discharged from the hospital, I called her at home as soon as she got home and asked her to take out her scale and get on the scale so I would know what the relative weight of the scale was compared to the discharge hospital scale weight. I knew that she was at risk to be admitted to the hospital, readmitted within 4 days, since there seemed to be a pattern going on there. So on the 4th day, I called her at home again and found out her weight, and her weight was up around 4 pounds. And as a result, I was able to titrate her medications. She ended up not being hospitalized during the weekend, and my nurse and I then started to trade off calls. And over 6 months, we called her every Monday and every Friday and titrated medicines in addition with having her come into the office for visits, and she wasn't hospitalized. So I think we were actually saving money. We were saving the system money through the use of an available technology called the telephone. And I think everybody knows what the telephone looks like. And now I'd like to talk about my second patient. So he is a 55-year-old man, really vigorous, young-looking 55-year-old man, ex-smoker. He came to see me with some chest pain, shortness of breath. He'd actually seen my nurse practitioner twice within the past month. Accompanying that chest pain and shortness of breath was some weight loss. And given his smoking status, it was very concerning. I sent him for a chest CT, and unfortunately he had a very large lung tumor that was already metastatic. So that was, it was a really unfortunate case. After around 4 months, he'd been seen by the oncologist. He wasn't doing much better. He was actually declining. Now, unfortunately, the oncologist didn't have access to a gateway or any way to communicate with the patient. And you know, cancer patients want their information. They want to know the day after what the test results showed. My practice did have a portal, and I was able to communicate the oncology test results to the patients. I continued to do this over approximately 4 months, and he continued to decline to the point where he had a lot of difficulty getting out of the house. And he suggested to me, why don't we Skype? Because Skype was available at that time. It was just starting to be used. So I said, that's a really good idea. And again, this was a guy that I had a great relationship with. He was a wonderful, wonderful man. He made a suggestion to me about how he would like to communicate with me as a physician to help manage his progressive condition. And over the next 4 months, I communicated through Skype with this patient once a week. But if you look at my medical record, it looks like from that point on, I had no contact with this gentleman. I managed to handle his pain medication regimen using Skype. And of course, I'd always have the electronic medical record open. And I actually managed his end-of-life care. The last visit that we had was 4 days before his death, was over Skype. And again, I think there's an example of how technology enables the relationship that a provider can have with a patient. So that makes it even more interesting. It made it really even more interesting for me. And I started to wonder, are there any studies about this? Do people use video conferencing? Has it been studied in clinical practice? Have there been a lot of studies around asynchronous messaging? Is there any integrated delivery system that would allow me to use that as a part of my medical record? And so I actually looked and I didn't find any, and I said, well, I'd be really interested to test this out myself. And again, when I say myself, I have to thank colleagues like James Stahl at the Institute for Technology Assessment and CIMMIT for supporting this work. And what we first did was a very small trial looking at video conferencing within an office practice. And all it was me, I'm the blue guy, looking at the screen, and a patient coming into my office practice and having a video conference visit, because of course for privacy and security reasons we couldn't get anything other than that through the IRB. So patients would come into my office, be enrolled in the study, and have a virtual visit with me followed by a face-to-face visit with me. I ran 30 subjects through it, and I have to say that the thing that struck me most was the patient response. So this was in 2006, and patients said, can I do this with you? So I don't have to come in. Would you start doing this? And I was shocked, quite frankly. So that led to a larger study, a randomized crossover study, in which we enrolled a lot of patients. We had more doctors. And you can Google Scholar this study. It's available. I'm not going to go into all the details. But it was a nice, robust study. And we looked at, we processed 152 patients through a crossover trial of face-to-face versus video conference visits. And then the patients would cross over to a different modality. One of the visits always happened with their primary care provider. So they always had a relationship with one of the doctors that was involved in the study. Both patients and doctors were surveyed after the study to look at whether or not they found it satisfactory, and we analyzed these statistics using descriptive analyses. I thought I'd just show you the kind of complaints that were evaluated. They're the same kind of complaints that you see in any internist general doctor's office, whether it's hypertension, knee pain, gastroesophageal reflux disease. These are the same types of complaints that people would present over video conferencing in this trial. Now let's look at the patient perception. I think one of the key, I would call it a fallacy about technology, is that patients really are worried about it getting in the way between the provider and the patient relationship. I think in the setting of an existing relationship, patients are very happy with technology delivering care. The patients thought that the clinicians paid attention to what they had to say. They had great clinical skill. Their manner was comfortable. They rated the overall visit slightly less, which is to be expected, but they were very satisfied with this type of visit. Physicians, a little uncomfortable with the inability to actually touch a patient, which is to be expected, and that's why you see this large gap in the exam. And I think that accounted for the overall discrepancy in the visit satisfaction. But interestingly, there are two really interesting things that came out of this study as well. One is we asked patients what was easier, opening up and launching the video conferencing software or scheduling an appointment with the office. The answer, I think you by laughing, you know what the answer is. They thought it was easier to open up the software than it was to schedule an appointment. And secondly, we also asked, there was a slight control group that had patients see one doctor in the face-to-face modality and another doctor in the face-to-face modality, really to control for the technology as the route to visit. So if you looked at the patients who saw two different doctors in the face-to-face modality, those doctors were less likely to agree on the diagnosis than doctors who saw someone in a virtual modality and the face-to-face modality. So really relatively stable reliability there. We also did another study in the practice. So since video conferencing could be used, I think, in certain special circumstances, but is not nearly as promising as asynchronous modes of communication with patients. We looked at template electronic visits that would allow patients to send a scripted complaint to the physician's office and have it then answered within 24 hours. We used a very commonly available portal that patients, that's commercially available, and satisfaction among the patients was in the 99% realm. Why did they like it? Prevented unnecessary trips to the office, gave them direct access to their physicians, eliminated phone calls, so really convenience and access. Why didn't they like it? This particular application didn't have the greatest graphic user interface. So really a technical barrier. They didn't find that the communication between them and the doctor was a problem, the cost of access was the problem, the internet access was the problem. It was really the graphic user interface, something easily correctable. So it appears that we have an opportunity to leverage here. We have readily available, ubiquitous technology. Everybody in here is carrying around a cell phone. Everybody here uses a desktop computer. So that's readily available. We have patients and physicians who, at least in the context of relationship, are happy to use the technology. And I'm not going to go into the reams of data that are now available from Kaiser Permanente, from group health that suggests you can cut a third to half of visits, improve quality. Cost question still remains to be answered fully. But physicians and patients like this stuff. So that led to a couple of questions. Now, if the majority of visits for providers are for chronic conditions like diabetes and hypertension and depression for follow-up, or they are for follow-up of laboratory tests for other tests, or they're also for the evaluation of new complaints that are acute and self-limited, then what if there was technology that we took advantage and leveraged the technology that's readily available to help us deal with these really common reasons for coming to the doctor's office? And through CIMIT, I have an association with biomedical engineers, and I thought to myself, what if in the case of my patient with CHF, there was a device similar to a bank ATM or an airport kiosk that would allow people to have their measurements taken asynchronously and pushed to a provider so that he or she could respond. It would be available for mass use so that you could put it in an assisted living facility, in a doctor's office, in a pharmacy, and multiple patients could use this device. And I managed to create a prototype with CIMMYT funding that is now functional. And we are starting some beta testing in the United Kingdom. Now, as people have said, you don't really want to test anything in the United States because the landscape is far too complex. Nobody wants to pay for anything. But in other environments where you might have a single-payer environment, people are far more willing to experiment and innovate around these types of devices. So, there's another what if. What if healthcare leveraged technology that already offers secure, direct access to personal and private information and allowed you to access that information through a PDA or a cell phone or your home computer? Kind of like online banking. Does anybody in here use Mint? Anybody heard of Mint.com? So Mint.com is a really cool site. It allows you to aggregate your financial data. You can look at your mortgage and debt. You can look at your assets, and you get a picture of your net worth. And actually, this morning, I got a text message from Mint saying that I had to pay my credit card today, or it would be a late payment. Wouldn't that be useful for healthcare? So let's go back to my patient who I did a lot of video conferencing with and a lot of email messaging with, the patient who unfortunately died of cancer. So this patient, let's call him Don, excuse me. Imagine if he had access to a place that had his record and would allow him to do administrative tasks like your common patient portal, but also start conversations with me in various modalities. So the modalities that I've talked about, like video conferencing or SMS text messaging. Imagine what the doctor side of this would look like. So instead of having a doctor schedule and all you're doing is seeing a list of patients from 8 o'clock to 12 o'clock that you're going to be seeing in face-to-face modalities, imagine if you're seeing patients in all sorts of modalities, where sometimes you might have face-to-face visits, sometimes you might have text visits, sometimes you might have video conference visits. Such as might also give you alerts. Just like I received an alert from Mint.com, wouldn't it be great to get alerts about my patients, clinically relevant alerts, while the administrative alerts about doing prior authorizations go to somebody who does administrative tasks? And wouldn't it be nice to have results that were integrated from a multitude of devices? Right? So if patients were having their data collected at a kiosk, having their data collected at home, all of that data came to my office and came to my attention if I needed to see it. It would also be nice to be able to quickly take a look at parameters that were of importance to the patient, so consider a diabetic patient. Looking at A1C, LDL, all of those parameters, but additionally, getting information from the patient that has been input into their record by the patient themselves, such as their social profile, such as their family history. And to relate to what another presenter said this morning, connections to their social networking sites. And in thinking about having a more proactive healthcare system, wouldn't it be great if I could actually push a message to a patient instead of simply respond about lab tests? And finally, wouldn't it be nice if I was looking at the record of a diabetic and I'm being judged on my population of diabetics, wouldn't it be great if I could actually move from that individual to my population back and forth and understand all the parameters that need to be managed, especially given this world of pay for performance. So I want it to be relatively simple here. I think there's an opportunity, if we leverage the relationships that people have with their patients, to take advantage of these readily available technologies. So Jefferson said this comment: information is the currency of democracy. Every time I go into the library with my kids, this is written across the wall of the library. I think this is a great comment. So if information is the currency of democracy, then maybe the relationship is the currency of medicine and healthcare. And maybe what we need to do is enable technology to access the right information to enable relationships that can be healing in healthcare. Thank you.